everybody, my name is Tanya Heineman. Myself and Oksana, we have created a presentation for you tonight on breast hypoplasia. It's also known as insufficient glandular tissue, short form is IGT. The reason we chose this topic is twofold. One, I recently sent a patient that came my way to Oksana. I wasn't able to fit her in the schedule. Oksana quickly identified IGT was missed by several other practitioners. This is something I see often. I actually had a case on Monday at the hospital and it was missed. So it's something that we're both very passionate about, and we decided to ask Dr. Salim if we could present on this topic. We don't mind questions, just because the nature of the presentation and how quickly it is. If we could just hold comments or questions till the end, that would be really appreciated if that's okay with everybody. Okay, bear with me because I'm using slides and I haven't used this in a presentation setting before. So, okay, so hypoplasia is simply a term that means underdevelopment or incomplete development of a tissue or organ. Hypoplasia in terms of breastfeeding is one of the reasons for primary lactation failure. And we know there's 3 different forms of primary lactation failure. So hypoplasia or IGT is one of those. This condition occurs when a mother's body does not make an adequate amount of milk for her baby, even when everything else is in order, including but not limited to the latch and positioning, breastfeeding frequency and exclusivity. The mother and baby are kept together. Baby's oral anatomy is fine, so no tongue tie, no cleft palate, etc. When we look at some of the factors for primary lactation failure, we look at things like previous thoracic or breast surgery that may sever critical nerves or ductwork. And of course, this wouldn't be evident post-surgery. It's usually not until a mother may be breastfeeding or, may have tried everything else. And we know just from the outcome of the baby latching and not producing milk and transferring and weight and all of that, we may not know any of these things. Hormonal complications, such as those that accompany polycystic ovarian syndrome. I think this is one of the more common reasons that we may all see. Retained placenta or thyroid abnormalities. Sheehan syndrome, a little less common, but that is another sort of primary lactation failure factor. A condition in which mammary tissue simply did not develop during adolescence, and patients presents with the signs of IGT, which is what we're talking about tonight. And of course, insulin-related conditions as well has been added to that list as well. Oksana, is there anything you want to add to that part?
No, that's okay. You just can use the, I think, the arrow, so to facilitate the slides going. There's an arrow down on the bottom.
Oh, there.
Yeah.
This one here?
No. Further, yeah, here. Mm-hmm.
This one, okay, cool.
Yeah.
Thank you. So hypoplasia of the breast, or IGT as it's also known as, is also called tubular or tuberous breast deformity or constricted breast in the plastic surgery literature. We'll show you some pictures that Oksana and I had put together at the end of the presentation. Previously thought to be a simple issue of cosmetics. So corrections are addressed corrections address the appearance of a woman's breast with little regard for their function. So if you haven't seen hypoplasia before or IGT, once we show you those pictures, it's pretty evident. It's a very common sort of look, and a lot of people just don't have the education or the knowledge. And so this could be, something that a woman might go and have a surgery for, and we're often not thinking about, well, we will be as IBCLCs, but oftentimes those people doing the cosmetic surgeries may not be thinking about breastfeeding or milk ducts or those important factors that we would be looking at. So more patients seek to breastfeed their babies, but little is known about what to do when breastfeeding doesn't work. So there are 3 categories of lactation failure. Preglandular, so that's due to hormonal issues such as a retained placenta or postpartum thyroiditis. I'm not sure how many of us have seen that. I've seen retained placenta often, and thyroiditis seems to be something that we see a lot of in Ontario. Glandular, everything after the baby is born that can get breastfeeding off to a bad start. So a baby that can't transfer milk properly for whatever that reason is, poor breastfeeding management, such as scheduled feeds, and extended separation of mother and baby. We're seeing them separated at birth, or babies in the NICU and mother can't get there, and short scheduled feeds as well too. Postglandular, so that's due to previous surgery, or hypoplasia, IGT. Sorry. So how to recognize IGT breasts? Well, it's all about breast shape, placement, and asymmetry. So that's what indicates IGT, not necessarily the size, because fat tissue can fill up the bra cup. And I love that Oksana created this slide in this way, because it's so accurate. So when we're looking at breasts that are IGT breasts, they're widely spaced breasts. So breasts that are more than 1.5 inches, 4 centimeters apart. Breast asymmetry, so one breast is significantly larger than the other, not always, but often. The presence of possible stretch marks on the breast in absence of breast growth, either during puberty or in pregnancy. And I think this is like the really key part about the puberty part. Tubular breast shape, so the breasts often look like empty sacs, and disproportionately large or bulbous areolae. And I had a mom on Monday at the hospital, and the nurse came up to me before I went in the room and gave me the rundown of when I was seeing this patient. And she mentioned, the first thing she mentioned was the areola, how it was very bulbous and it was puffy, and there was no medical reason. So it was really interesting, because she had never seen something like this before. So absence of breast changes in pregnancy, postpartum, or both. So this is sort of an example of what we're looking at. So the first picture here on the left side where it says normal would be normal breasts. Obviously, it's a diagram, it's a picture, and we know breasts are usually different shapes and sizes as well. But when we get into type 1, we can start seeing the tubular size of the breast starting to change. Type 2, you can kind of start to see it a little bit more emphasized. Type 3, very common to see that in IGT. Type 1 and type 2 more easily missed. And then of course type 4 would be really evident visually as well. And so the mother would be like very much aware that during puberty, her breasts almost stopped developing or didn't continue to change. And so most moms are not surprised, because they already know it's their breasts, right? They know that things look different. So why does IGT happen? Well, there's lots of different sort of parts to this. So one of the reasons is exposure to high levels of certain environmental contaminants, so namely dioxin and other endocrine disruptors while in utero that can predispose insufficient breast growth during adolescence and pregnancy. Girls' breasts may grow during puberty, but perhaps that growth is asymmetrical, or the breasts are large and appear normal, but only the fatty tissue develop, not the glandular tissue. And that's the key point, I think, to this entire presentation right there, if we had to sum it up. Only fatty tissue, not glandular tissue. This could be a result of hormonal regularities that occur with some endocrine conditions. So you're more likely to see IGT with women who experience PCOS, also uncontrolled thyroid or insulin-related conditions. The mom I mentioned on Monday had both PCOS and diabetes as well too. Some mothers with hypoplasia, IGT report a luteal phase defect. So that definitely can impact their fertility journey. And they'll see a lower than normal progesterone happening as well in the presence of ovulation. So just really interesting how, we might not find out till breastfeeding, but these things have been occurring all along too. So intervention is really important. These cases of endocrine irregularities are especially important to address because the hormone issues that interrupted the development of this glandular tissue may be preventing what milk-making tissue is there for doing its job. I think the big piece here is that education is key for healthcare practitioners If we want women to breastfeed, if we're seeing these issues pop up, the earlier that we can intervene, even through puberty and prenatally, etc., it helps the functionality for breastfeeding. So early intervention is important. Normalizing hormonal irregularities can help to maximize the performance of the glandular tissue that is present. And that's why certain medications and even herbs may have the effect of boosting the milk production, those galactagogues that we all know and probably talk about every day. However, as we all know, what works for one mom may not work for another. And this area needs ongoing research for sure. Understanding our own body and health, asking questions about medications or behaviors. The doctor recommends during one's preconception time, even in, being a young adult as well, going through puberty, being at a healthy body mass as well can really help to normalize our hormones as well too. So it starts early, doesn't it? Does IGT breast always mean low milk supply? So some people with physical markers noted above will have no trouble bringing in a full normal milk supply after giving birth. Some patients will be able to wean off supplementing in a few months postpartum, and some when baby is well on solid. So every person we're treating as an individual, making no assumptions how IGT may affect everyone. A prenatal breast assessment that reveals the physical characteristics consistent with hypoplasia, IGT, should prompt extra attention to getting breastfeeding off to the best possible start. Can this be done with a midwife? Can this be done with an OBGYN? Are these possibilities that we maybe not are doing right now in our assessments? Special attention should be paid if a patient does not notice any changes in their breast during pregnancy as well. How to help. So if lactation failure of a glandular nature is suspected, preglandular and postglandular factors must be accounted for and properly ruled out. Ask the patient, what measures have you tried? What other possible causes for this have you explored? And this approach shows respect for the person's journey. Really important piece to all of this, right? Women are already super sensitive about our bodies, especially our breasts, so showing the utmost respect, talking to women about IGT, I think is really important. There's no easy way to have that conversation. We want to make sure that we're doing a full review of all of the factors that could contribute to the problem of insufficient milk production. Refer to the skilled IBCLC. We're here to help at OBN because the journey might be long and curvy, as Oksana has nicely worded it. Each patient is assessed individually with a customized care plan because we know a one-size-fits-all approach generally doesn't work for breastfeeding mamas. And Oksana also put a really great support group here as well too for IGT mamas on Facebook, which is really helpful. How we can help. So what we often do is use an SNS supplementary nursing system as soon as possible and make sure the patient is comfortable with that. A 5 French tube will do the job in the early days for sure. If an SNS must be used longer, a professional product would fit better due to better cleaning, more convenient use. A lot of moms don't love using SNS and certainly not very long as well. With a different tube diameter as the baby gets bigger as well. And then our references, which we're happy to share. We may have to add in a few extras because I think I still had a few cuts and pastes to do. So, Oksana, is there anything else you want to add?
Oh, just the pictures and we're finished.
Oh, yes. Okay, the pictures, that's right. Oh, where are the pictures?
Exactly, I was looking for...
No. Okay, just bear with us. This is our first time here. I wonder why they're not showing up. I know they're
7 and 8. 7 and 8.
7 and 8. Oh.
Yeah, and
7.
8 now and 8.
Okay.
8.
Oh, I skipped over 8. Okay,
yeah.
Here we go. That's right. These are the ones. Okay, so as you can see in our pictures here, this is another, these are better visuals than the hand-drawn sort of characters. But these here kind of give you a better understanding of the positioning. So we see that distance between, we see the tubular shape, and we see the really dramatic change from breast to breast which is not always so with IGT, because sometimes they are like, I don't know if you can see my cursor going on the right side, the bottom left picture here. So in those cases, sometimes you don't have the dramatic difference like you do. Oops. In some of these other pictures that might be really, really dramatic as well. But the main thing that we're looking for is the distance between in the tubular changes. And then, you know, through our intake with the mother, asking those questions about what happened in puberty, how was her prenatal journey, conception, etc. as well.
Also, sometimes spacing, it's not the only indicator, because sometimes a person can have a wider chest and spacing can be just wider just because chest is bigger. However, look at the development of the quarters and look at the nipples, how they face each other. Very prominent sign of nipples of IGT could be nipples looking to each other, like pointing to each other nipples, or pointing down, or pointing very apart, right? So it will tell you that some parts of the breast are not developed properly, but it's always about how many babies, what's lactation number. With each lactation, they're supposed to get bigger and better tissue. However, it's not the case always, but if mom had a successful lactation, like she was trying to feed her baby previously, like previous baby, she has good chances to have a little bit better lactation with the next one. So, because it's a gland, it can develop.
Absolutely.
That's why we are making the plan